So we are at San Patrignano, a therapeutic community, the biggest actually in Europe, and maybe not only Europe, but in most parts of the world. San Patrignano, which is situated about 10 kilometers south of Rimini in Italy. And today we had the pleasure to listen to Alan Francis, who was the chair of the task force for DSM-IV, the manual used as a base for diagnosis of psychiatric illnesses. So we say welcome to you, Alan Francis.
Thank you.
Could you just tell us a bit about your thoughts now after the DSM-IV, because we understand that you are a bit critical of the over-diagnosis made by the possibilities that has been opened through the DSM-IV. Could you just elaborate a bit on that, please?
Partly it's us, but it's partly the way the world works and the power of drug companies, so that we try to be very conservative in making changes. And only 3 new diagnoses were introduced in DSM-IV. But we underestimated the power of advertising and marketing, and there have been 3 epidemics, all in child psychiatry, in the past 15 years. One of them, the most outrageous, is an epidemic of childhood bipolar disorder, which leads to a tremendous overuse of antipsychotic medications, which can cause a great deal of weight gain and are quite harmful. The second has been an epidemic of attention deficit disorder, which has doubled in its incidence. And here we made very few changes, but the drug companies came out with new products that were off patent and very aggressively marketed them to physicians and also to patients and families. And so the rates have doubled, the rate of medication has doubled, and autism has increased by 40-fold during the course of these last 10 years. For reasons that are complicated that we go into if you're interested. But I think even if you're very careful and conservative in your diagnostic approach, it's very, very likely that anything you write that can be misused will be misused, and the diagnostic inflation will come even with the best of intentions and great care. My concern for the future is that DSM-V, which is meant to appear in about a year and a half, is very ambitious in its goals and is making many suggestions that are likely to dramatically increase the rates of psychiatric disorders and to medicalize normality. And I think what will follow inevitably from this is a great increase in the use of medications which are already being massively overused. And I think that this is something that people need to attend to and try to change.
Speaking at the conference here in San Patrignano, you mentioned one example about grief, which is quite a normal thing if you've lost a loved one. Could you just tell us a bit more about, or more or less repeat what you said at the conference?
I think that this is an example of excessive ambition sort of departing from common sense. That in DSM-IV, if you have symptoms of sadness, of loss of interest, trouble with appetite, trouble sleeping, loss of energy, and these are related to losing someone who you love dearly, then that's not considered major depression. That's considered normal bereavement. Mammals love, mammals attach, mammals grieve. Not just humans, but even chimpanzees and other mammals. It's important that we respect the dignity of this and the rituals that are built up to help people during their grieving period, not medicalize it. Call it major depressive disorder, and the suggestion is that often people get pills for what's absolutely normal grief. Stuff like that makes no sense to me.
So sooner or later, more or less, anything that is related to human behavior might be regarded as an illness.
Well, that's a problem that's already with us. That 25% of the population of the U.S. Is labeled as having a mental disorder every year. That in Europe, there's a recent lifetime figure of 38%. A prospective study found that by age 32, half the population would be diagnosed with an anxiety disorder, 40% with depression, 40% with an addictive disorder. So we're reaching the point where it will be impossible to live a lifetime without getting a disorder diagnosis. And many people will accumulate several. We're medicalizing the normal experiences, the normal everyday aches and pains and disappointments and imperfections of life. Now, there is a tremendously valuable arena for psychiatry to practice in. There are people who have clear-cut disorders who are reliably and accurately diagnosed, for whom we have remarkably effective treatments, both psychotherapeutic and medication. What we should be doing is devoting our resources, our attention, our time, and our money to treating the people we treat best in ways that we know work. Instead, the tendency has been to create a bubble of diagnostic inflation with people who are on the fuzzy boundary with normality, misallocating resources from those who really need it to those who don't, and in fact the people who would be much better off in terms of stigma and reduced cost and reduced side effects if they were just left alone.
You have written about this, haven't you?
Quite a bit.
Did you write a book about this?
No.
If people want to learn more about your thoughts on this, how would they be able to access it? Where can they find information?
Oh, it's a cinch. The blogs contained in Psychology Today or the Psychiatric Times, and I must have done more than 100. So that everything I've ever thought about is down there, expressed much better than I could ever say it here extemporaneously.
Now, with this new system of diagnosing what used to be normal behavior, who are the winners and who are the losers?
I think there's a tendency to believe the worst in people and to assume that those who are coming up with these ideas, which I consider to be so off base, are doing it for financial gain or to create more patients for psychiatrists. And I know the people doing it, and that's completely untrue. So that they have no interest at all in helping the drug companies, no interest at all in helping the private practitioners. They're doing it because they believe in it. And they think that what they're doing would be very helpful. And it would be if they were the only ones doing it. The trouble is that experts always assume that the things they write will be used by others the way they would use it and the way they mean it to be used. And it's absolutely not like that. That anything that can be misused in the diagnostic system will be misused. Anything that can be misunderstood is likely to be misunderstood. And that anything that allows the drug companies a possible marketing advantage will be heavily and aggressively used. So that many of the suggestions would be okay if they were restricted to the person who writes the suggestion, but can be absolutely disastrous in the hands of the average practitioner who may have only a few minutes with the patient, who may have samples that have been foisted on him by the drug company salesperson, and who is seeing patients who've been advertised to sufficiently so that they insist, I really need this medicine. I saw on television, it's very helpful, doctor, can't you give it to me? So the winners will be the drug companies. The losers, I think, the winners will be the drug companies, and there will be some patients who will benefit from the new diagnoses because it really will be helpful. The losers, I think, will be the people who are misidentified, those who receive harmful medications that they didn't need, the people who really do need help who don't get it because of the misallocation of resources, those who are stigmatized. And I think that in the long run, this will be very, very harmful to the credibility of psychiatry. So psychiatry is a wonderful profession, done well within its limits. We'll be losing credibility by being too ambitious and expanding our borders beyond our area of competence.
Thank you very much.
Thank you.
You've been listening to Alan Francis talking to you from the conference at San Patrignano in Italy.